Good morning students. Today's class we will see about the obstetric labor. In modern obstetrics care, it has led to a virtual disappearance of obstetric labor in developed countries. However, in underdeveloped countries, obstetric labor is not uncommon. That means the obstetric practice there means disappearance of obstetric labor from developed countries, but still in developing countries we can see the obstetric labor. Obstetric labor is one of the 4 leading causes of direct maternal cause, and the most important fact is obstetric labor is an outcome of a neglected and mismanaged labor. We can see the definition of obstetric labor. Obstetric labor is one where, in spite of good uterine contraction, the progressive descent of the presenting part is arrested due to mechanical obstruction. It may result either due to the factors in the fetus, that means the passenger, or in the birth canal, that is the passage, or both. So there can be fault in the passenger as well as in the passage. For example, if it is a big baby and a small pelvis, and the obstruction can occur because the patient may have good uterine contraction but the baby is not able to pass through the pelvis. So further progress is almost impossible without assistance. Causes. We can see the fault in the passage. First is the bony, the pelvis. The first is the bony pelvis. The cephalopelvic disproportion and contracted pelvis are the common causes. Secondary contracted pelvis may be encountered in multiparous women. Then soft tissue obstructions. This includes cervical dystocia due to prolapse or previous operative scarring, cervical or broad ligament fibroid, impacted ovarian tumor, or non-gravid horn of the bicornate uterus below the presenting part. Fault in the passenger or in the fetus. It includes transverse lie, broad presentation, congenital malformation of the fetus like hydrocephalus, fetal ascites and double monsters, big baby, occipital posterior positions, compound presentation, locked twins. We can see the morbid anatomical changes that takes place during the obstetric labor. The first is the uterus. The morbid anatomical changes in response to the obstruction have already been described in relation to the formation of pathological or retraction ring. We have seen the last video in the abnormal uterine action. We have seen it, but the lowest uterine segment elongates and becomes progressively thinner and accommodate the fetus driven from the upper uterine segment. The things we have to keep in mind that in obstetric labor, the contraction will be normal. The patient will have as the time goes, the contraction will become more and more severe. So, because of these contractions, the lower uterine segment becomes thinner and thinner. And a circular groove encircling the uterus is formed between the active upper uterine segment and distended lower uterine segment that we call it as a pathological or ring or Bandil's ring. Due to a pronounced retraction, there is a fetal jeopardy or the even death of the fetus can occur. And next is the bladder. The bladder becomes an abdominal organ. Normally the bladder is in the anterior of the uterus. But when there is an obstetric labor, when the contraction goes on, the bladder becomes an abdominal organ due to compression of urethra between the presenting part and symphysis pubis. The patient fails to empty the bladder. The transverse depression at the junction of the superior border of the bladder, distended lower segment, often confused with Bandil's ring. Bladder will get traumatized, which may lead to the blood-stained urine, a common finding in the obstetric labor. And the base of the bladder and urethra, which are nipped in between the presenting part and symphysis pubis, may undergo pressure necrosis. And the devitalized tissue become infected and later may slug off, resulting in development of genitourinary fistula. That is the reason why the formation of genitourinary fistula in obstetric labor. The reason is that the bladder and urethra is nipped between the presenting part and it may undergo pressure necrosis and later it may infect and slug off. And these things we cannot see in the first or second day after delivery. It may take 1 or 2 weeks after the delivery. So the patient may develop the genitourinary fistula, or patient may come back to the hospital with the complaints of passage of urine to the vagina only after 1 or 2 weeks of the delivery. Next is effects on mother. The immediate effect include exhaustion due to constant agonized pain and anxiety. Dehydration is due to increased muscular activity without adequate fluid intake. Metabolic acidosis due to accumulation of lactic acid and ketones. Genital sepsis is invariable accompanied especially after the rupture of membrane with repeated vaginal examination or attempt to manipulation outside. An injury to the genital tract includes rupture of the uterus, which may be spontaneous in multipara or may be traumatic following an instrumented delivery. Postpartum hemorrhage and shock may due to isolated or combined effect of tonic uterus or genital tract trauma. All these will lead to increased maternal morbidity and mortality. The death due to the rupture of uterus, shock and sepsis with metabolic changes. Remote complications of the remote effect on the mother include, even if the patient survives, the following may occur. First, a genitourinary fistula or a rectovaginal fistula, variable degree of vaginal atresia, secondary amenorrhea following hysterectomy due to rupture or due to Sheehan syndrome. Effect on the fetus include, first is asphyxia, result from tonic uterine contraction. It interferes with uteroplacental circulation or due to cord prolapse, especially in a shoulder presentation. Acidosis due to fetal hypoxia, maternal acidosis, and intracranial hemorrhage is due to supermolding of the fetal head leading to a tentorial tear or due to traumatic delivery. Infection, all these lead to increase the pain. All these four factors or the four effects will lead to the fetal loss or the fetal death. The clinical features include patient is in agony with continuous pain, features of exhaustion and ketoacidosis. Abdominal palpation reveals upper segment distended and tender. Pathological ring placed obliquely between umbilicus and symphysis pubis and rise during the course of time. Fetal parts may not be well defined. FHS is usually absent. And how we can diagnose? First thing is the pathograph will recognize impending obstruction early. If the labor is slow to progress, careful general abdominal and vaginal examination is necessary. And the woman will give a history of prolonged labor and labor pain becomes severe and frequent and bearing down effect can be seen. General examination of the patient shows features of maternal distress, exhaustion, ketoacidosis, dehydration, tachycardia above 100 beats per minute, rise in temperature and scanty urine. Abdominal examination reveals retraction ring or the Bandil's ring is felt between tonically contracted upper segment of the uterus and distended tender stretched lower uterine, that is somewhere between the umbilicus and the symphysis pubis. Distended urinary bladder. FHS shows evidence of fetal distress or even the FHS may be absent. Internal examination reveals or vaginal examination shows vagina dry and hot with discharge. Means often this discharge will be offensive. Cervix is fully dilated. Membranes are absent. Cause of obstetrical labor can be revealed. The presenting part is extremely molded and jammed in the pelvis. There is usually a large catput formation. The management of obstetrical labor. First is the preventive. Obstetrical labor is the preventable. By good obstetric service and risk assessment, we can find out, we can detect the patients who are likely to develop obstetrical labor. Those cases we can tell annatally. Annatal detection of factors like produce prolonged labor like big baby, small woman, malpresentation and position. Internatally, continuous vigilance, use of pathograph and timely intervention of a prolonged labor due to mechanical factors can prevent obstetrical labor. Failure in progress of labor in spite of good uterine contraction for a reasonable period of 2 to 4 hours is an impending sign of obstetrical labor. So these cases we can take it for cesarean delivery as early as possible. The actual or curative management include the underlying principles of the curative management include first to relieve the obstruction at the earliest by a safe delivery procedure, to combat dehydration and ketoacidosis, and to control the sepsis. These are the three principles under the management of obstetrical labor. The curative treatment, it includes the immediate management, general management, and obstetric management. The immediate management is the correct maternal dehydration, contraction, prevent by tocolytic drugs and blood samples sent for grouping and cross-matching if it is not done early. General management include assessment of vital status of the mother, general condition of the mother, IV fluid to correct dehydration, and broad-spectrum antibiotics, catheterization and sodium bicarbonate infusion to correct acidosis, and the obstetric management. We can see the obstetric management. For the preliminaries, first the fluid electrolyte balance and correction of dehydration and ketoacidosis is done by a rapid infusion of ringer solution. At least 1 liter is to be given running through. At least 3 liters of fluid is required to correct the clinical dehydration. Second, a vaginal swab is taken and sent for a cultural sensitivity test. Blood samples is sent for grouping and cross-matching if it is not done earlier, and a bottle of blood should be at hand prior to any operation intervention. Antibiotic, usually ceftriaxone 1 gram IV is administered after the test dose. IV infusion, metronidazole is given for the anaerobic infection. And obstetric management, before proceeding to a definitive operative treatment, rupture of uterus must be excluded because by the time the obstetrical labor come to a management, sometimes the rupture of uterus may happen. So before we proceed to a further management, we have to exclude the chance of rupture of labor, rupture of uterus. A balanced decision should be taken about the best method of relieving the obstruction with least hazards to the mother. Frantic attempt to deliver a morbid baby by method of ignoring the risk involved to the mother indeed a bad obstetrics. There is no place of wait and watch, neither any scope of using oxytocin to stimulate uterine contraction. That means once we diagnose this patient as an obstetrical labor, there is no time should be wasted to wait and watch. So it has to be intervened as early as possible. And vaginal delivery, baby is invariably dead in most of the neglected case, and destructive operation is best choice to relieve the obstruction. If, however, the head is low down and vaginal delivery is not risky, forceps extraction may be done in a living baby. There is no place of internal version in obstetrical labor. After a completion of delivery, the expulsion of placenta, exploration of the uterus and lower genital tract should be done to exclude uterine rupture or tear of the uterus. In cesarean section, if case detected early with a good fetal condition, cesarean section gives the best result. But late and neglected cases, even if the fetal heart sound is audible, desperate attempt to do a cesarean section is to save the morbid baby often leads to a consequence. Not infrequently, the baby is either delivered stillborn or dies due to neonatal sepsis. So the postoperative period of the mother also becomes stormy, at times ends fatally. Symphysiotomy. The place of symphysiotomy has to be duly considered in developing countries as an alternative risky cesarean section, because in developing countries and underdeveloped countries there is not much chance for the cesarean sections available in every hospital. So in those cases we can go for a symphysiotomy. This can be done in the case of established obstruction due to outlet contractions with a vertex presentation having a good FHS. A woman in labor requires a supportive environment with a skilled birth attendant who can provide a good clinical and empathetic care. Proper management of the labor includes accurate diagnosis of labor, correct use of partograph, and appropriate interventions when problems arise. Good clinical management of the labor and delivery prevents maternal and neonatal morbidity, mortality due to obstetrical labor. Proper management of normal labor is essential to prevent obstetrical labor. Continuous and thorough assessment of the woman and her fetus contributes to limit negative outcomes by providing opportunity for timely and appropriate treatment. If obstetrical labor is identified, prompt treatment is required to save the life of the woman, if not always possible to save the life of the fetus. Thank you. Thank you for listening.